Okay. Hi, my name is Sarah Brodersen. I'm with Sydney Dietze today. We are students at Mount Mercy University and are going through the class of Advanced Physical Assessment, Pathophysiology, and Pharmacology. Today we'll be discussing the neurological system, including the anatomy and pathophysiology, as well as how multiple sclerosis is related to the neurological system and affects it. So the objectives today are to describe the anatomy and pathophysiology of the neurological system, recognize abnormal physical assessment findings that characterize multiple sclerosis, and lastly, to summarize diagnostic testing, treatments, and symptom management options for multiple sclerosis. So I like to think of the neurological system as the control center. It sends impulses to provide all kinds of functions for the rest of the body. So this will control functions within the body through either electrical or chemical impulses. The neurological system functions by using sensory integration and motor output. I like to think of sensory as putting your hand on a hot stove. That hot stove will cause a reaction to your receptors, and this will cause an integration process. The integration process is a process in which the body decides what it's going to do based on your hand being on that hot stove. The motor output is actually going to be the action. So me pulling away my hand from that hot stove is how the body is going to react to that hot surface. So neurons are nerve cells. They are core cells within the neurological system. Each neuron takes a different function and responsibility within the body. The three components of a neuron is a cell body, which is also called a soma, dendrites, and axons. So the cell body or soma is mainly found in the central nervous system. Multiple cell bodies within the central nervous system are called nuclei. If they're within the peripheral nervous system, they're called ganglia. Ganglia's main function is to move impulses to and from the central nervous system. So the soma is going to be here. It's going to be in the centralized area, and that's going to be the main part of the neuron. The dendrite is going to be this thin branchy part of the neuron stemming off of the soma. So the dendrites are another component. They are an extension that carries nerve impulses toward the cell body. So they're going to take information and bring it into the soma. Axons are the last component. They carry impulses away from the cell body. So those are these little yellow spots here. So those are going to carry information from the cell body and out toward the nerve endings. So do dendrites or axons carry impulses toward the cell body? And the correct answer is dendrites. Nerve impulses. So neurons are able to send impulses or communicate with one another from neuron to neuron, or from neuron to a muscle as well. They're able to communicate from one neuron to the next through a structure called a synapse. These impulses can be done through electrical or chemical impulses. Most impulses are chemical, though. Electrical impulses are characterized by ions that flow between neurons. A chemical impulse is caused by presynaptic neuron releasing neurotransmitters. So a neurotransmitter is a chemical released to excite or exhibit the target neuron. A good portion of the neurological system is your central nervous system, which is characterized by both the brain and spinal cord. Within the brain, there's three different areas. So the forebrain, the midbrain, and the hindbrain. Within the spinal cord, this would be more of like your extension to your periphery. So the brain is a complex organ that is responsible for thought, vision, breathing, temperature management, or AKA every process that regulates our body. There are 4 different lobes of the brain. The first being the frontal lobe, which is the part of the brain that functions to allow us to express language, allows us to plan and organize, allows us to have voluntary movements, and controls responses as well. The parietal lobe is in charge of sensory, perception, taste, hearing, sight, touch, and smell. The temporal lobe is going to be in charge of hearing, processing emotions, and language. And lastly, the occipital is going to be in charge of vision perception. So connecting the brain to the rest of the spinal cord is your brain stem, which is characterized by the pons, the medulla oblongata, and the cerebellum. Your pons is part of the brainstem, which is in charge of like your brain wake cycles as well as your breathing. Your medulla oblongata is going to be in charge of the heartbeat, breathing, and blood pressure, which are all involuntary. And your cerebellum is going to be in charge of your walking, your posture, your balance, coordination, and eye movements, and also speech. So we have our lobes in the brain, but we also have 2 separate hemispheres. So we are separated into the left and the right hemispheres. The left, as you can see here, is going to be in charge of logic, ideas, sequencing, facts, math, analytics, and right field vision. Your left side of the brain is actually going to affect your right side of the body. And your right hemisphere is going to be in charge of creative, holistic perception, arts, feelings, and imagination. So this hemisphere is actually going to affect your left side of the body. So if you were to have a stroke within one of the hemispheres, then the opposite side of the body would be affected. So if we ended up having a stroke on the right side of the brain, then it would actually affect your left side. So the peripheral nervous system is another part of the neurological system. The peripheral nervous system is separated into the somatic and autonomic systems. The somatic is in charge of voluntary actions and conveying sensory information. This is in charge of nerves that carry sensory signals from the body to the central nervous system. And it also has nerves that carry motor signals from the central nervous system to the skeletal muscles. So this is a good example of this. This person is moving their arm and their hands so that impulse is going toward the muscle from a neuron to a muscle to actually excite it and control that movement. So that's not super spastic, but in an actual coordinated motion. Autonomic nervous system is the other part of the peripheral nervous system. This is in charge of involuntary systems such as regulating your digestion, heart rate, breathing, etc. The autonomic nervous system also regulates the activities of internal organs, including your heart rate or digestive organs. It also is in charge of internal homeostasis and is a big part of its responsibility. It's also in charge of sympathetic and parasympathetic responses. So your sympathetic is going to be your fight or flight response, and your parasympathetic is going to be in charge of your rest and digest. So this is an example of that. So you have your sympathetic system over here and what that's in charge of, as well as your parasympathetic over on the right side. So nursing assessments for the neurological system, we're going to assess a patient's level of consciousness, if they're alert or lethargic. You're also going to assess their orientation status. So time, date, place, name, are they confused? We're going to assess their memory based on short-term and long-term. Their speech, are they slurred? Are they having racing thoughts and speaking really fast or really slow, not making sense? We're also going to assess their balance, coordination, motor functions, and gait. This can really give us a good idea of a patient's neurological assessment. We're also going to assess their cranial nerves, their pupils. Are their pupils reacting to light? Are they round, equal? And we're also going to watch reflexes. This can be like your brachial, your radial reflexes. We're also going to assess sensation if somebody has any numbness in their feet or extreme pain somewhere. So these are all going to be assessments that a nurse will do.
Okay, so we chose multiple sclerosis or MS for our condition to research more closely. We both agreed that the disease process was interesting and would just have a lot of information to research. The prevalence of MS has also been rising quite a bit in the United States, so it's something we'll probably see a lot more of. Okay, so MS affects about 2.8 million people globally and about 1 million here in the United States. This is more than twice the previous number from a study done in 1975, as well as the studies following that. Peak onset for MS is about 25 to 35 years old, but MS can occur in young children or older adults. It also tends to be more prevalent in the Caucasian population with a Northern European ancestry, and it affects more women than men. Women are actually 3 times more likely to be diagnosed with MS than men. And it has been suggested that hormones may play a role in MS susceptibility because of this. So this slide just kind of describes the economic burden of MS in the United States today. So MS is the leading progressive neurological condition of young working-age adults. The average cost of medical expenses of those with MS is about $65,612 annually. Disease-modifying therapies are actually estimated to be a large portion of this cost. And then the total economic burden of MS in the United States is currently $85.4 billion, with direct medical costs being $63.3 billion, with the 3 largest cost components being prescription medications for these patients at 54%, clinic administered drugs at 12%, and outpatient care at 9%, and then indirect costs being about $22.1 billion. And then this chart just kind of breaks down those indirect costs a little bit more. Okay, so pathophysiology. MS is a demyelinating autoimmune disease. The immune system is attacking the healthy tissue in the CNS, attacking myelin sheath on sensory and motor axons. Following this myelin deterioration, oligodendrocytes attempt to repair the damage, and this results in the scar tissue formation. These plaques interfere with nerve transmission, and this results in the variety of symptoms dependent on what nerves are affected. The areas most commonly affected are the optic nerves, the cerebellum, cerebrum, brainstem, as well as the spinal cord. And then eventually the axons themselves will eventually degenerate, and this results in the irreversible damage associated with MS. Okay, the breakdown of the blank is the key characteristic of multiple sclerosis. And then the answer is myelin sheath. Okay, clinically isolated syndrome, or CIS. This is one of the MS disease courses and refers to a first episode of neurosymptoms caused by inflammation or demyelination in the CNS. So, like I said, an acute neuro episode with no prior history of demyelination, with the symptoms lasting more than 24 hours. So absence of fever, infection, or encephalopathy. Symptoms can include weakness, paresthesia of the face, trunk, or limbs, impaired gait, visual changes, and incontinence. So people who experience CIS or clinically isolated syndrome may or may not develop MS. If the CIS is accompanied by an MRI with brain lesions detected, they have about a 60 to 80% chance of developing MS in the future. And then if the lesions are not detected on an MRI with the CIS, they have about a 20% chance of developing MS in the future. MS physical assessment. So physical symptoms, again, just may vary due to the location of the lesion or the plaque. Most common symptoms reported include fatigue, depression, weakness, numbness, difficulty with coordination and balance, spasticity, and pain. Spasticity occurs in about 90% of patients, and it's most commonly occurring in the lower extremities, resulting from main motor pathway involvement in the spinal cord. And then cognitive changes can occur. 50% of patients with MS experience cognitive changes. These changes are like memory loss or impaired concentration. Severe cognitive changes like dementia are very rare with MS. And then visual changes occur due to lesions in the optic nerve or the connections. And then it is also very common for these patients to experience bowel, bladder, and sexual dysfunction. And then remission and exacerbation of these physical symptoms are characteristic of MS. So these exacerbations can last several weeks to up to 3 months, and they occur about every 1 to 3 years. And this remission exacerbation characteristic of MS occurs in about 85% of these patients. So nursing assessment. So a nursing assessment with MS patients should address their neurological deficits, complications secondary to their MS, and the impact of their diagnosis on the patient. You should observe the patient's gait to assess for balance and coordination. This is important to determine their risk for falls or injury. And then determining the patient's strength and symmetry, observing for bilateral or unilateral weakness. Assessing again for those visual changes and impairment. This is again important for risk of falls and just any risk of injury. Addressing those issues with incontinence and bladder spasticity, any issues with swallowing or speech, possibly referring to a speech pathologist for further evaluation of that. And then additional assessments are the patient's compliance to their medication regimen, as well as how the patient and their family are coping with the diagnosis. So to have an MS diagnosis, you have to have 2 or more episodes last at least 24 hours apart, or last at least 24 hours and occur at least a month apart. So an MRI with contrast is the best diagnostic tool, and this can help observe for those lesions or plaques. Cerebral spinal fluid may also be evaluated for the OCBs or IgG, and the OCBs are found in about 90 to 95% of MS patients, and the IgGs are found in about 70 to 90% of the patients. And then again, it can just be extremely difficult to diagnose due to varying symptoms dependent on where the lesions are in the brain. So pharmacotherapy, so these are more of the disease modifying agents, so immunomodulatory agents. These reduce clinical attacks of new lesions and decrease the symptoms. And then typically patients are on 2 or more of these agents. And route for these can vary. You can get intravenous infusions, oral. There's just different routes that you can take for that. And then corticosteroids are used for acute relapses to decrease that inflammation and symptoms and then attempt to induce that remission. So, with a acute relapse, the corticosteroids are typically a 3 to 5 day course intravenously. And then there's some examples of those. And then immunosuppressants reduce the risk of clinical relapses and suppress T cell immune reactions. And then those are 2 common ones used with MS. So here's some symptom management. So for spasticity, baclofen is the medication of choice for that in MS patients, and it's really common to see these patients on it. It can be given orally or by intrathecal injection for severe spasticity. Other medications may be used to treat it, but baclofen is the first line choice typically. Fatigue, anti-dyskinetic agent is actually used, and that's a first line drug to relieve that fatigue, interfering with the ADLs. Fatigue is often the most debilitating symptom of MS, so it's important to get that under control. And then ataxia, or the difficulty with coordination, is a chronic problem that is most difficult to manage. Some classes used to manage this include beta adrenergic blockers, anticonvulsant agents, and benzodiazepines. So then for bladder and bowel dysfunction, this can be difficult for patients just maintaining their dignity and independence. So a variety of pharmaceutical agents may be needed to manage it. So anticholinergic agents are used, alpha adrenergic blockers, and antispasmodic agents. Bethanechol and oxybutynin are commonly prescribed for MS patients. So self-management strategies. So first, just measures to improve that bowel and bladder function. Implementing a voiding schedule to improve bladder function can be useful. So just ensuring that they're going to the bathroom at least every 3 hours and then consuming about 1,500 milliliters of fluid daily. And then self-catheterization is common with MS patients and has been shown to improve bladder control. Adequate fluids, fiber, and a bowel training program are also effective for the bowel issues such as incontinence and constipation. And then implementing daily exercise. Walking can improve gait in MS patients. It's just important to ensure that they're using their assistive devices as needed, and also ensuring that they're getting adequate rest in between exercise and not overstrenuating themselves. And then daily exercises to stretch muscles can minimize the risk for joint contractures. And then also, again, just avoiding the extreme fatigue or becoming overheated, because this can exacerbate MS symptoms. So, like I said before, just ensuring that they're getting appropriate rest periods in between activity. And then implementing measures to avoid injury. So, actually patching each eye and alternating several times daily can actually improve balance and coordination in MS patients. And then just making sure that they're aware that their peripheral vision can be affected. So scanning the environment when they're ambulating and just removing any objects in their home that may cause falls or injury. And then being careful with hot surfaces and hot water due to the sensory deficits that come with MS. So procedural therapy. So The stem cell transplantation is being newly looked into for MS. So it uses your own stem cells and collects them from your bloodstream and freezes them. And this works by resetting the immune system. It may slow the course of MS and repair nervous system damage. It's actually a one-time procedure, so 3 weeks is spent in the hospital prior to the treatment or the transplant, preparing your immune system and using chemotherapy to do that. So after the chemotherapy, the stem cells are infused back into the body through a vein. And again, this therapy is still being researched to see if it's useful in decreasing the inflammation associated with MS. So holistic management, providing the patient with reliable resources for education so they can be informed on their diagnosis and just have that sense of control. Emotional support resources such as MS support groups or patient and family counseling. This can be really important due to the depression and anxiety that's associated with an MS diagnosis. So just making sure that they're being supported in the emotional aspect as well as the physical. And then providing the patient with financial support as needed. Like I talked about previously, it can be extremely expensive for treatment. So social work referral may be important to assess insurance coverage, prescription assistance, things like that. And then just again, informing the patient about ways to improve wellness, such as the daily exercise, relaxation techniques, and effective coping strategies. Again, just due to the depression and anxiety that's associated with it, and just finding ways to better control that aspect of it. So prevention measures, we don't know the exact cause of MS yet or exact risk factors. There's new evidence suggesting these new risk factors and how they're associated with triggering autoimmune inflammatory disorders. So one is the vitamin D. So new evidence has suggested that low vitamin D levels may play a role in MS development. So just increasing vitamin D levels through sun exposure may protect against immune-mediated diseases like MS. And then smoking has been shown to increase MS incidence, so just not smoking. Having a healthy lifestyle and a healthy diet. Obesity in early childhood and adolescence has been linked to the development of MS later in life or more heavily associated with it. And then avoidance of some viruses and bacteria. There's increasing evidence linking previous exposure to like the Epstein-Barr virus and human herpes virus 6 to the later development of MS. So in conclusion, multiple sclerosis is an autoimmune demyelinating disease characterized by exacerbations and remissions of symptoms such as fatigue, spasticity, cognitive changes, as well as many other manifestations. MS is manageable through pharmacology and some lifestyle changes, but is not curable.